Colleagues, we are at the top of the hour. Welcome and thank you for being part of our session today. This session is made possible given the funding support from the Gates Foundation to ASLM and partners. And our session today is convened on the World TB Day with a very catchy commemorative theme of led by countries and powered by people and partners at different levels. Today's webinar covers plastic waste management in healthcare, and certainly waste management should be led by us, the generators, and powered by us with support from partners. From Gray literature, we know that plastics account for up to between 25 to 36% of healthcare waste. And this translates to about 15 million tons of plastic waste generated from healthcare settings annually. And if we take it that up to about 42% of healthcare waste, including plastics, are incinerated, then there is a significant environmental impact based on that handling approach, let alone other handling approaches to the plastic waste that we generate in healthcare setting. As every entity is responsible for its carbon footprint, the healthcare sector therefore should also begin thinking clean service provision and probably securing carbon credits in exchange for the contribution we make to greenhouse gases in the atmosphere. In today's session, we will explore materials that are used in diagnostic tests, the quantities of plastic that we generate from some of the assay methods that we use, and then, of course, current approaches and tools used in quantifying plastic waste. And, of course, the implication of diagnostic waste data for laboratorians, policymakers, and manufacturers. And I have the honor to present to us two speakers. Our first speaker is going to be Professor Alice Street. And Professor Alice is a professor of anthropology and health at the University of Edinburgh. And she is a principal investigator of the Wellcome Trust-funded project. The project is the After the Single Use, Rethinking Medical Devices for Reuse, Resilience, and Renewal. She has published widely and in the area of anthropology and other health systems strengthening. And of course, she's very interested in looking at the history, circulation, and reimagining the single-use plastic in global healthcare from a historical and anthropological perspective. Our second presenter is going to be Professor Maiwen Karsudis-Keros, and Professor Maiwen is a professor of microfluidics engineering at the Heriot-Watt University in Edinburgh, still in the United Kingdom. She leads a multidisciplinary group that does the designing of new point-of-care test structures for liquid biopsies application, and she has also developed a 6-hour metagenomic workflow for rapid pathogen detection from blood. She is also an investigator of barriers and solutions to more sustainable diagnostic devices. Colleagues, let me hand it over to the two presenters, and then we'll get back with questions and answers at the end of this exciting session. Professor Alice, over to you and Maiwen.
Fantastic. So Francis, thank you very much for the introduction and welcome to all the participants. We are delighted to be here today to share our research in diagnostic plastic waste, and we're very grateful for the support that ASLM has shown to our research. So I'm Maiwen Karsudis-Keros, and as Francis said, I design new point-of-care tests. I'm really interested in new biomarkers, including the use of cell-free DNA for infectious disease diagnostic. But while I'm designing and prototyping, developing these new point-of-care tests, I find myself confronted to the fact that all the devices that I create are in plastics and single-use. So I have looked for solutions to make my lab more sustainable in the first place. But when I met Alice Street, a professor of anthropology at the University of Edinburgh, who came from a completely different angle to the same issue of the environmental sustainability of point-of-care diagnostic. She really helped me look at the big picture and realize that this environmental sustainability issue is in fact not a problem of just my lab, but a sector-wide problem. So today, together, we want to share our perspective on plastic waste in the diagnostic sector. So we'll start by talking about the scale of the problem, bearing in mind that we're talking to an audience with strong experience of dealing with point-of-care and laboratory diagnostic waste. We'll then go into more material detail and discuss what we found about material usage in point-of-care tests. Then we'll share a tool that we've started to develop to help researchers understand the amount of waste created by diagnostic lab in a safe way and in a way that could help laboratory worker to do data collection to create a body of evidence to take back to policymakers and manufacturers. And finally, we will conclude by looking at what the future might look like and how we might replace some of the petrochemical plastics found in diagnostic tools by more sustainable alternatives and what this really entails. But first, why should anyone be interested in medical waste? You will know that the healthcare is responsible for about 4% of global carbon emissions, and approximately 6 to 10% of national health emissions come from medical devices, which include diagnostic devices. And we need to understand what drives the carbon emission of these diagnostic devices in order to reduce it. In the UK, there is a strong emphasis on decarbonization at a governmental level. The NHS in England has been the first health system in the world to pledge to become net zero. They want to reduce 80% of their emissions in the next 10 years. The problem is that for the NHS is that carbon emissions are very much embedded into so-called Scope 3 emissions. So Scope 1 emission concerns what fossil fuels are used to run these healthcare facilities. Scope 2 is all the electricity consumption, and Scope 3 is pretty much everything that falls beyond NHS control. And that includes medical devices and diagnostic devices, which are made by separate companies. However, the NHS has some sort of means of control, and that is through procurements. So a green procurement timeline towards environmental sustainability has been published by the NHS in 2020. And in these, we have a series of milestones. So for example, since April 2022, all the NHS trusts should include a 10% weighing on net zero and social values towards any new product entering the procurement system. But whilst we've not researched this in detail, through ad hoc conversations with various stakeholders, our observation is that this milestone is a little bit loosely defined and is not applied in the same way everywhere and to the same level. We have also not yet heard of case studies of products that have been chosen for their sustainability credentials, even though maybe they were a little bit more expensive. It doesn't mean that they don't exist, but they have not yet been communicated. In this timeline, there is another important milestone in April 2028, where all suppliers should produce a carbon footprint for all products that they are trying to sell to the NHS. And if applied, this could have far-ranging effects, making companies with effectively greener products very competitive. It's a real way to incentivize the market It's a real tool for change. Sadly, there is hearsay that this might not be applied to the letter. And why? That might be because it would mean that every company will require carbon footprint calculation. This is usually done via a tool that is called life cycle assessment. So a life cycle assessment is a standardized scientific method used to quantify the environmental impact of a process, a product, or service through its lifetime. And per product, these typically cost between $5,000 to possibly $100,000 US dollars, depending on the complexity of the product. So that would be costly and difficult to implement for some companies. So in this presentation, we'll also discuss life cycle assessments at various points. And so we'll touch again upon this. But for now, I want to take the discussion away from the realms of the United Kingdom and back to Africa, where it really all started with Alice.
Thanks, Mai-Wen. So really lovely to be here, and thank you so much, Collins and Francis, for inviting us and organising this meeting. So I'm a social anthropologist. Most of my research has focused on the ways in which global health funding, priorities and intervention are reshaping health systems around the world. I've carried out research in Papua New Guinea, in Sierra Leone and in India. And my interest in diagnostics stems from the growing recognition of the urgency of improving access to diagnostics globally and the increased investment in development and deployment of diagnostic devices, especially in health settings with limited infrastructure. So I have been interested in seeing how this rollout, the investment, the development and deployment of point-of-care tests, but also laboratory strengthening, is reshaping health systems and care. And some of this research was carried out in Sierra Leone. And what we looked to do was try and follow qualitatively the life cycle of diagnostic devices as they entered the country, as they were used, and then as they were disposed of. And in fact, when we started this research, the disposal wasn't really a part of a priority for us. It wasn't something we saw as a particular point of interest. But in talking to health workers and laboratory workers, from community health centres up to referral hospitals, we found out that actually one of the biggest challenges that point-of-care testing posed was the increased volumes of waste and the fact that the resources and infrastructure simply wasn't available to manage that. So we mapped the life cycle of diagnostic devices, and then we also were interested in what makes diagnostic devices not only available, but also usable. And to try and get to this, we conducted surveys to try and find out what infrastructure was available that is actually needed to make these tools usable at the point of care. And part of that survey was focused on waste management infrastructure. Next slide, thanks. So some key findings. So we found out that LFAs, so lateral flow assays, which are usually designed for use at a community level, were used in every level of the health system. So from community health centres to up to the laboratories of general public hospitals. And I'd be super interested to hear whether anybody on the call today also uses LFAs in your labs. We also found that only 47% of community health centres actually had a functioning incinerator. And this is interesting because this was only 3 years after the end of the West Africa Ebola outbreak, when there'd been significant investment in providing incinerators in rural health facilities. So many of these incinerators that weren't functioning were only 2 or 3 years old. Which speaks to the lack of ongoing investment and maintenance of waste management infrastructure. We also found that healthcare waste that was segregated at the point of disposal was often actually recombined when it left the health facility. And that healthcare waste was then either openly burned in areas outside the health facility, it could have been buried, or in many cases it was actually sent to municipal landfill, with obviously significant implications for waste workers who are working in those sites as well. Next slide, please. Okay, so there are some key lessons from this research. One is that we saw that access and diagnostic access has been increasingly prioritized in global health policy and funding. But while access is prioritized, the waste infrastructure is often deprioritized or considered an afterthought. Second, we found that because of this, the costs of diagnostic waste, both in terms of financial costs of managing and disposing of that waste, and we know that ASLM has been doing really valuable work in providing some tools to quantify those costs, but also other kinds of costs in terms of the health and safety issues of diagnostic waste not being safely disposed of, in terms of the potential for that waste to be burned or buried, and the environmental and human health harms that can follow from that. All of those costs are sort of delegated to users. And in fact, we did a review of IFUs of many diagnostic tests, and we found that the vast majority of IFUs in their waste disposal instructions simply instruct users to follow national guidelines. And so that indicates the kind of lack of responsibility being taken on at the level of manufacture for the costs of waste disposal. And so this focus on speed and access also removes incentives for manufacturers, regulators and policymakers to consider the impact of waste. And this is what Maiwen was talking about in the NHS, where the government is trying to bring in some kinds of incentives for manufacturers to try and consider environmental harms in their design and manufacture of devices. But at a global health level, we really haven't seen these kinds of incentives put in place. Okay, next slide. Okay, so these findings about the scale of waste and the problem of a kind of lack of interest at a global health level in trying to address it led Maiwen and I to want to investigate actually what this waste kind of is made up of. And this was during COVID-19. So we took 22 COVID-19 LFAs. Many of them had been approved by the WHO's emergency listing procedure. And we manually deconstructed these lateral flow assays into their smallest component. And then we weighed those components in order to try and establish just how much plastic waste and other kinds of waste are being produced by these devices, but also to compare them and to see whether there were any kind of good models for best practice that could be identified already on the market. Maiwen, could I have next slide? So we actually found some quite interesting results. So the first finding was that actually there was a really huge weight variation between kits. So the weight of kits varied from 13.7 grams to 84.6 grams. And what we found is that actually some of the sort of newer tests, often self-test devices, were real outliers here in using electronics and much heavier materials and much more packaging, which obviously produce more waste, but obviously these devices are still only serving the same function as the lower weight tests. We also found large variations in the proportion of the weight of the overall kit that was made up of plastic. And we found that a lot of the waste generated was from packaging rather than from the core test components. And interestingly, some of the tests with the lowest cassette weight, so some of the tests actually were just strip-based and didn't use a standard cassette casing of a sort of hard plastic casing for the testing strip. So some of the tests that used just a strip-based test and didn't have any hard plastic casing still had the overall highest weight of our sample. And so one example there is, which you can see on the first graph on this slide, is the quick view at home test, which actually scores quite high on overall weight, but as you'll see from the next slide, is actually the cassette itself is very small. The test itself is very small, and we presume that this might be because they use huge amounts of packaging in order to sort of compensate for the small size of the test itself. So if we can go to the next slide. So you can see the quick view test is right in the middle of this slide and doesn't have a hard cassette casing, but as I mentioned, had one of the highest overall weights. And then next to it to the right is the Illume test, which is one of these electronic self-testing kits, which you can see is much larger and more substantial than many of the other cassettes and the cassettes that you probably are familiar with in your labs. And is really an example of over-engineering and unnecessary plastic waste, because as mentioned, ultimately that engineering doesn't contribute to the performance of the test. Okay, next slide, thanks. Okay, so key lessons from this research was that given there's large variation in the amount of overall waste from testing kits, and also the variation in the weight of the cassette itself and the amount of plastic waste produced by the cassette itself, this shows that there are actually lower waste options already available on the market. So there are already choices to be made between more sustainable and less sustainable devices. We found that there are easy wins available in the packaging. The packaging makes up quite a large proportion of the overall waste. And these two findings led us to try and make a case for the WHO and other organizations who are producing target product profiles for new tests to include environmental criteria like the proportion of the overall mass of a kit that should be made up of packaging or that should be made up of plastic in their target product profiles. So target product profiles, as I'm sure many of you already know, set out some kind of minimum and maximum ideal criteria for specifications that a new medical device should meet in order to meet the needs of the market. And they often provide guidance for industry to design and develop new tests. But up until now, environmental criteria have largely been absent from these target product profiles. Again, this would be a place where we could improve incentives for manufacturers to start taking environmental harms and impacts into consideration. This is important because it's important that we don't only see the user as the producer of waste. So what we see from this materials weighting research is that actually waste is produced across the entire life cycle of a product, and waste is generated at the point of design as well as at the point of use. And this means that responsibility for waste also needs to be distributed across all of the stakeholders involved across the whole life cycle of a device. So that includes the regulator and the manufacturer. Of course, this doesn't mean that there aren't also things that can be done at the point of procurement. And the fact that we found that there is actually substantial variation in the tests available on the market. And we'd be interested to know whether this is true for other devices beyond LFAs, does suggest that there is a role for procurement in potentially comparing and evaluating devices and procuring the most sustainable ones that are already available. Next slide. Okay, so this work on weighting the amount of plastic in tests inspired us to consider in more detail some of the materials that are used in diagnostics and other medical devices. So we were really interested in how difficult it is to actually find out what materials are in a device. This information is often not on the label of a medical device, and it's often not included even in the brochure or the IFUs on a device either. So to address this, we followed our original deconstruction method of taking devices apart into their individual material components. But then we took an extra step of then analysing each material using a method called FTIR to identify the specific materials that were being used. Can I have the next slide? So this is what we ended up with for a single malaria LFA. And what is perhaps most surprising here is just how many different components we were able to deconstruct our device into, and how many different plastics were found in this one single kit. And there are some interesting choices here. So the cassette itself is made from polystyrene, and this we've just found is very common across all LFAs. But styrene gives off dangerous gases both at the point of production and also when it's burned, especially if it's burned at low temperatures, as, for example, I found waste was being incinerated in Sierra Leone. Also, we found that PVC, which is written there as polyvinyl chloride, is used as the backing for the testing strip. And PVC also has been found to be harmful to human health, and many of the additives that are added to that polymer are harmful to the human health and the environment. So that raises questions about why PVC is necessary for the backing of that strip. And then lastly, in the packaging, in the top right corner, you can see an image of the cardboard box into which these kits are packaged and distributed. Contains bisphenols, which have also been found to be an endo-disrupting additive, which is often added to polymers and materials to give it some kind of waterproofing or increased rigidity, and so. But in this case, it's just been added to the packaging. So that was an interesting find as well. So can I have the next slide, please? So overall, we found 20 different components in just this one single malaria test and 6 different plastics. And we found the presence of several harmful materials and additives, PVC, bisphenols, and polystyrene. And we were also interested again that some of those harmful chemicals were found in the packaging rather than in the core test components. Next slide, please. Okay, so key lessons from this are that materials data is not publicly available. There's very little traceability in tests in terms of where the supply chains for the materials that they're made from. That when we think about environmental harms, we need to think about the issue beyond just wet chemistry. I know that ASLM has been working really hard on GTC that is used in cartridge-based gene expert tests. And have done some fantastic work on that. But we can also think about some of the other materials that are used in medical devices and laboratory-based testing. And that the harms that these materials do might not only also be confined to the point of disposal. We might need to think about how they might have leakages both at points of production and also use in the laboratory as well. And then the materials analysis work kind of raises interesting questions about why certain materials are being used. And the next step in our research is then to interview manufacturers and to try and find out more about why specific materials, especially harmful materials, are being used and whether and what the challenges are for using more sustainable alternatives. This data is also important because when people do life cycle analysis, like Mai-Wen was explaining earlier, is now very often used in the UK in order to establish the carbon footprint of a new medical device. When people do a life cycle analysis, they often don't have that data available for what materials are in their device, and actually knowing what materials are included in their device is important for calculating the carbon footprint. And so they often have to make assumptions about what those materials are. So this data can help to give a more accurate picture of that carbon footprinting. And then last, at the moment, we've been really focusing our research at a device level, but obviously in the real world, in a laboratory or in a point of care setting, devices are always incorporated into practices and procedures. And so there is obviously a need to scale up our research to think about what kinds of devices and what kinds of materials are being used at a procedure level, not just a device level. And with that, I will pass back to Mai-Wen.
So with the previous projects, we have delved deep inside specific devices, understanding namely the lateral flow assay. And indeed, the data that was obtained from this FTIR study, so the material study and the weighing, enabled us to develop a full life cycle analysis for one of our lateral flow assay produced by AcuBio, a company in Scotland. It was a COVID-19 LFA that was distributed during the pandemic. We have found, thanks to this analysis, that every single lateral flow assay produces 60 grams of CO2. Now, that might not seem a huge amount, but multiply by the billion tests, just a billion tests used per year, although it's probable that in the world we're using more like 3, 4 or more billion LFAs per year. But just taking 1 billion per year, that's the equivalent of 60,000 tons of CO2 per year. But now the question is, how do we scale these to an entire laboratory? So conventionally, people have measured laboratory waste by conducting a waste audit. So there's been a recent meta-analysis study conducted by Slutzman, and this reviewed more than 2,000 waste audit studies, and they ended up including 156 studies in their meta-analysis. What they found there is that 50% of waste audits had been done in high-income countries, and less than 5% had been done in low-income countries, presumably because of the cost associated. So the researchers surveyed the participants, and they found that overwhelmingly, people are doing waste audit to improve local waste sorting policies or practices. But people also want to reduce waste in general. And there's many other reasons for conducting waste audit, which include informing policy development, quantifying greenhouse gas emission, feeding into this life cycle assessment, etc. So quantifying waste can provide robust data that is needed for effective implementation of waste reduction strategies at financial, operational, and legal level. The problem is that waste audits are traditionally use-based. They include collecting physical waste produced by a lab, and they can be incredibly difficult. First of all, you need permission, you need a place to sort the waste, you need people that will need training, and the safety risk is very high. You're dealing with infectious and potentially infectious waste. Can be very disruptive for the service, the health services as well. One advantage of the use-based waste audit, where you open up the bins and count, every single item in the bin, is that if well done, it can be highly accurate. So people have looked at other types of audits, which are procurement-based audits. Now, access is not necessarily easy. we have found that usually there's not one single point of information for procurement, because procurement might be done in part at the lab level, maybe in part at the hospital level, and so it's not one single point that can give you all this information. But we have also found anecdotally that in certain places, procurement is a little bit politically fraught, and people can feel actually unsafe sharing procurement contract where this data is available. Now, in terms of cost, it's all paper-based, so it's quite low compared to the use base, but the accuracy might not be as high, although the disruption would be also lower than a use base. But neither of these solutions is ideal, which is why we're proposing a third way, an alternative, which is an audit via public documentation. So we believe that this combined with laboratory test volume can be incredibly rapid and completely safe way to assess overall laboratory waste. And that could be really useful for labs who want to understand how to reduce their environmental footprint. And such audits could help also researchers rapidly identify which devices are the most used, which assays are which assays use the most single-use items. So of course, this approach demands that there is a national accreditation service that makes the detail of these assays performed by each lab public. And in the UK, we're fortunate to have these documents public, but I'm aware that this might not be the case everywhere. So last summer, we put this idea in practice and we targeted a lab in Dundee in Scotland. So we accessed the schedule of accreditation, which is issued by the United Kingdom Accreditation Service, or UKAS. This is a public document. There's one for every single diagnostic lab in the country. They list all assays performed by this lab, and they make reference to the SOPs used for these assays. So you know exactly how these assays are conducted on what machine. Apologies for this interruption. Thank you. Importantly, this UKAS documentation is also updated every year. So taking these UKAS documents, what we did first is extract all individual assays listed in these documents. And then we consulted the reference SOPs and manufacturer instructions. All of these documents are also public. And so from this, we were able to list every single use item for all the assays. And we produced a heat map of single-use diagnostic consumable for that lab. So let's have a look at how this heat map works. So in terms of input, we have the broad category of laboratory assays divided in bacteriology, parasitology, mycology, serology, and molecular biology for this lab. Then in the next column, this is the type of assays. And in the column after that, we have the subtype, which might be the same assays, but used for a different sample type, which will bring different single-use consumable. And then we have the individual consumable identified. So there's a zoom in, and you see things like microscope slides, cover slip pipe tips, inoculation loops, etc. All the sort of single-use item you might find in a typical lab. And so in terms of outputs, what we have is that for each assay, we have a list of single-use consumable that is used in this assay. And then we can also derive the number of individual single-use consumable for each assays, but also we can look at the number of total single-use item across this assay menu. And so we can know from a laboratory perspective how many pipette tips are needed and And we can do a number of statistics like this. So, okay. So example findings from these preliminary studies that we found that bacteriology represented 24% of consumable use in this lab, and that virology represented about 75% of consumable use. We found that pipette tips were the single most present consumable across all assays, and we found that the detection of viruses contained the most individual single-use consumable of all assays. And so we're able to do statistics such as the top 8 most used single-use consumable across various sections. So here I show it for virology, for example. And these sort of data can help labs taking a number of actions, which could be maybe using more sustainable pipette tips or finding other ways to reduce the number of pipette tips. And then once they've done that, move on to the next top item. But it could also, these statistics could also be used to target a particular manufacturer that is sort of guilty to use a lot of ancillary single-use components. We have found in this preliminary study that maybe counterintuitively, some of the assays that use cassettes or cartridges, we think of it as the cassette or cartridge representing the test, but actually there is a lot of ancillary single-use components that support the use of that core item. And in the traditional diagnostic, which uses just, say, agar plate and inoculation loop, there's actually a lot less single-use consumable. And that's something that will be maybe very evident for people working in labs, but maybe outside the lab and to the manufacturers, and to the procurement people, this has not been made evident. And so we hope that this sort of data could help bring these things up and influence policymakers and procurement teams. So the key lessons from this is that accessing physical waste is very dangerous and time-consuming and costly as well, and so not really feasible everywhere. Procurement approaches often there's no single information point, and there can be politically fraud. So this new audit format that we're proposing via public documentation could enable non-disruptive assessment of consumable used in any lab. I want to flag some limitations. It's not suitable for waste management costing. It does not cover some ancillary equipment. It doesn't cover at present wet reagents, and it would rly on assay statistics for completeness. It does perform a different goal to waste cost analysis tool, which was presented a few weeks ago, but could be complementary and actually could use also the same web-based platform. So final key lessons is that we developed this tool to enable understanding of waste generation from diagnostic tools, to enable comparison of waste generation between different diagnostic tools. And it's not financial costing, although it could be paired with financial costing. The key features, it's not currently operational. I just want to flag this. It's a concept that has been tested in one lab in Scotland only, but it enables researchers to understand waste generated by assays. It could have a huge potential impact, including supporting research in diagnostic waste and supporting lobbying manufacturers and policymakers for more sustainable products and targets. Future work will involve waste-based development, testing in different laboratories, and testing ideally against a use-based audit to compare the accuracy. So I would like to take a few minutes, or maybe just literally 1 or 2 minutes, to for you to scan this QR code and give us some feedback on this proposed alternative waste audit via public documentation. So you can scan this QR code with your mobile phone. And I think that Francis and his team are also going to put in the chat the link, the direct link to this survey, so you can click on it on your computer or any other device that you're using.
Excellent, excellent piece there. Comprehensive content and should I say very optimized delivery from the two professors with us here today. There are so many questions. Our Q&A space is buzzing, and please keep the questions coming. We will deal with what we can now, and then the rest will come through with the materials when we share them. We'll share all the questions with Alice and Mywin, and then they will get us the responses, those that we cannot deal with. But just to quickly say one or two things, that speed and access really decentralizes other aspects, including waste management, the need for speed. But it's interesting that one of the profs here is actually involved in the development of some of these materials, and in their space, this discussion should already be going on even before a new challenge comes through. What materials are available? Are we trying them out so that then when time comes and we need them, we're not running around for the materials, but we're just looking for the antigen antibodies that then get embedded in the materials. There is also the aspect of costing service delivery. I think it is a high time that we begin now costing our service, health service delivery, not only to the point when the service is delivered, but up to the point when the waste generated from that service delivery is done. And then finally, the last bit that is of interest to me is the fact that some of the waste that are generated, segregated well at the point of generation, actually get desegregated at the point of final disposal. And again, this takes us to the fact that we are responsible for our waste disposal up to that point when it is finally disposed of. Now, with those, we have so many questions, and I will start with, in no particular order, I will start with one from Victor. Victor is saying the presentation and others is a great analysis, especially with the materials. And he agrees with reduction of waste by design at the point when we're manufacturing some of these one-time devices or even reusable devices. But what would be the end game, he is asking? How can this impact development of sustainable treatment technologies? Because we're working on reducing waste, and then we're also working on developing treatment technologies. So the two corners, how is the reduction in waste going to impact the treatment technologies? Let me stop it there and hand it over to you, Mywin, and see what your thoughts are around this.
So the tools that we've presented here enables us to collect some data to evidence what is the waste created and what materials are involved in the waste and what is their impact. With these data, we can understand what materials can be replaced by more sustainable alternatives. But we can also, put this data back to manufacturers, policymakers, and procurement specialists who don't necessarily see the waste in the same way as laboratory workers do. And so I think data collection is incredibly important to design the solutions for tomorrow.
Great. I don't know if Alice would want to say something to this.
What I could add is, from an anthropological perspective, what I'm interested in is how Things that we think of as material objects, as objective scientific objects, actually have social and cultural values built into them. So when we make design decisions, they're influenced by cultural norms and social values. And so what I would really like, my end game, what I would really like to achieve is actually a shift in what those norms and values are amongst regulators and amongst global health funders and policymakers, so that when we talk about access, we don't see that as being in tension with questions of sustainability. We see the two things as going hand in hand, so that whenever we're designing for access, we're also always designing for sustainability, and both those values are kind of held up at the foreground.
Great addition there. And let me move that line a little further, because I think if we think the final activities that are going to happen from the start, then it helps us with what we do from the beginning. And so, Professor Mai, when coming to the aspect of the design, and you're in that space, now, is this discussion already happening? At what scale from the designers and manufacturers, so that us who will make the buy or not buy decisions based on the materials that are in the devices that we use, we are not put on the wall, because we're going to be doing verification studies to see which ones are giving us valid testing. But also we're going to be so worried about what is it that will happen at the end of the tunnel in terms of waste management. So how much of this discussion is happening in that space of device development in terms of sustainable devices put out?
So what we've seen with Alice from the target product profiles is that before the pandemic, we've seen a little bit of an increase in targets pertaining to sustainability. And when COVID happened, all these targets were forgotten and functionality, was the only consideration. We would like, with the data that we've produced, that policymakers put environmental targets back on the agenda, which will force manufacturers to act. Now, there are manufacturers all around that are looking into solution. So CFID has a big program on reducing GC. You've had some webinars on these, but they also have a program which I don't think they've been talking yet much about on reducing plastic waste and changing the virgin petrochemical plastic that are currently used into alternative, for example, bio-based plastics made from plants rather than oil, and that help reducing the petrochemical plastic. So it's possible that at some point these devices come on procurement desk, and you might have the choice between two of them. But of course, the procurement systems need to have something in place that enables the person doing the procurement choice to have, a rigorous comparison of products, and that will come with more effort on the life cycle assessments. I also see a number of startup companies across the globe proposing more bio-based solutions for lateral flow assays. Our fear is that that maybe there's not enough sort of fundamental work to understand the differences between these new plastics and maybe to avoid unintended consequences of things not looking as, exactly, as they are.
I would say that we've also talked to many manufacturers, and what's interesting is how much momentum there actually is around a desire to reduce single-use plastics and reduce plastics amongst manufacturers in the medtech space. But what they really are looking for is that prompt from their customers, that this is something that their customers value and prioritize. So I think it is also about sort of communicating to manufacturers that there is a market for more sustainable devices.
If I may, Francis, we haven't had the time to look into this. But we, as I've said earlier, we have started doing a life cycle assessment of a lateral flow assay. And this assessment shows that the carbon is embedded in the materials used rather than transport or manufacturing per se. And within these materials, we see that the heaviest component of the lateral flow assay is the cassette that package the strip. And that's something that could be changed to lower the carbon footprint. And so we've started actually looking at a library of potential replacements to virgin petrochemical plastic. And that's what you see in this image, are prototypes that we have developed that use alternative materials. So these include recycled leather. This includes recycled plastic from washing machines and fridges, and other possible sort of byproducts of other industries, which could help save between 20, 30 to 50% of the CO2 footprint. But what is really important is that we don't rush committing to any particular material, but we really assess these materials from a holistic point of view, looking at the functionality, biological testing, but also costs. Are they more expensive? Could actually people save money by using these alternative materials? But also from a legal and regulatory requirements, what do regulators think? And would this be approved by FDA? And so we can't, look at, this from a single perspective. We have to look at the holistic perspective for these replacement materials.
Interesting piece there. We have about 3 minutes to the end, and Alice, let me know if you guys may want to say something about the survey that is out there. If you're beginning to see some responses there, I'll give you a minute to do that. But I think the last question or comment we're going to be dealing with is what actually I dealt with in my summary after the session, which speaks to the fact that even the users, we were the end users of the diagnostic devices. We should know that it is our responsibility to move our waste to its final resting place. And therefore, the costing of that has to be done as well in our service delivery. And that will then inform us on which items to utilize and which ones not to utilize if the cost is not bearable by our healthcare system. But let me hand it over to you if you have something to say about this survey. One person will deal with the survey and then the other one will give us the closing remarks, if there is anything in the survey that you may want to deal with. And I promise that we will get you other questions that have not been answered, and then we will have the answers maybe by Monday and have those form part of the materials that we'll be going to our participants. Over to you, Maiwen. I think you're more than ready.
Unfortunately, Francis, I can't check live the answers, but we'll do that after the after this webinar has ended. So I'll leave Alice to give the closing remarks.
Great, thanks so much. Thank you everybody for listening and engaging with us. So I think very quickly, we have sort of 3 key takeaways that we want to emphasize. First, that clearly reducing waste is an environmental priority and needs to be considered more at every stage of laboratory management, planning, procurement, and also at earlier stages of manufacture and design. That reducing waste then needs to be tackled holistically, that we can't just assume the responsibility is with end users. It needs to be addressed across the entire life cycle of a device. And then lastly, we just want to emphasize that we're really keen to hear from you. Unfortunately, I wasn't able to see the Q&A, but I hope we'll get all of the questions sent to us. And We're really keen to know what you all think, and especially what you think of the waste audit tool, because this is a practical thing that everybody can do at a laboratory level to measure their waste, and then to use that data and leverage it to talk to procurement, or even to kind of, if we can collate that kind of data, that's where we can put pressure on manufacturers and regulators. So any collaborations are very welcome.
Thank you very much, excellent speakers, and thank you to our participants. You participants are the reasons we organize all this. And be sure we will send all the questions and the materials to you so that you can continue referencing to these materials and utilize. And of course, Wayne and Alice will get back to you not only with the questions, but with additional requests, given that you're good experts in this space, so that you can continue supporting our community of practice with your perspectives of waste management and waste handling, generally speaking. So from us, ASLM, do have the best of your morning, afternoon, or evening, depending on where you're joining us from.
Thank you for having us.
Thank you.
Good day.
Thanks. Bye.